conversation. I am Dr. Dhiren Gunjwala from Ahmedabad. With the help of my colleague, Dr. Vikas Jain, we will be hosting today's webinar. We appreciate your keen interest in developing your soft skill. First of all, I would like to answer the question why we selected this topic. We communicate very frequently in our practice, in our OPDs, with patients in the wards. Most of our communications are straightforward, but some of them, some communications are really difficult, and they are difficult from two perspectives. Sometimes the patients are difficult to deal with, and sometimes the situations like complication, declaring the poor prognosis makes the communication difficult. And usually at such point, we feel that probably the communication skill we have is inadequate. And with that idea, we are like hosting this webinar, or we are planning this webinar. Now, first of all, I would like to tell about our faculty. We have really 5 experts with us. The first expert is Dr. Jennifer Varghese. She is a pediatric orthopedic surgeon in California, USA. Interestingly, she is a chairman of Communication Committee of American Academy of Orthopedic Surgeons. She trains surgeons, physicians, and other healthcare professionals about communication at Kaiser Permanente, a very famous HMO in USA, and various orthopedic societies. The second expert is Dr. Ram Chadda. He's a spine surgeon from Mumbai, and he's a vice president of Indian Orthopedic Association. The third expert is Matthew Varghese. Matthew Varghese is head of the orthopedic department at St. Stephen Hospital, New Delhi. He is a dedicated teacher and very popular amongst postgraduate students. Though he is an orthopedic surgeon, last year he uploaded a video on how to manage COVID patients or the COVID situation. And surprisingly, that YouTube video became viral. And only yesterday I checked the views. It has more than 7.2 million views. Wow. Really, that's a credit for orthopedic surgeon. And in addition to that, Bill Gates has appreciated his commitment and passion by including him in the list of heroes in the field. So very rare achievement for any orthopedic surgeon. Another expert is Dr. Pichai Sridharanan. He's a joint replacement surgeon at SIMS Hospital in Chennai. He was a president of Indian Society of Hip and Knee Surgeons. Professor Ajay Puri is chief of orthopedic oncology and professor and head of Department of Surgical Oncology at Tata Memorial Center and Homi Bhabha National University. He is the immediate past president of Asia Pacific Musculoskeletal Tumor Society and founder president of Indian Musculoskeletal Oncology Society. We have 2 facilitators. The first one is Dr. Vikas Jain. He is a vice president of Western India Orthopedic Association. His current focus is 3D printing, and he works to bring the state-of-the-art technology to India and make this technology affordable to our patients. I am Dr. Dhiren Gunjwala. I am a pediatric orthopedic surgeon practicing in Ahmedabad, and I am the current president of Pediatric Orthopedic Society. Before we start our session, I would like to give you the brief outline. In the first 10 to 15 minutes, we have a short presentation from Jen, and she will be giving us the broad overview of difficult conversation. And after that, we will have interaction. And through that interaction, we will try to bring various aspects related to this topic for you. So with that, I hand over to Jen for her presentation. Over to you, Jen. Welcome.
Good morning for me. Good evening for you. Thank you so much. And I'm excited to hear what you all have to say and think about the approach that I and we have taken in my world. So I'm also a pediatric orthopedic surgeon with Kaiser Permanente, and we have about 10% of my time is spent discussing communication with physicians and surgeons. And one of the ways that we have amplified this is really talking about difficult conversations in particular. So let me get to sharing my screen. So share screen and window. And let's see. Please excuse my technical difficulties, but let me see if I can cancel all of this, go back to entire screen. Please let me know when you're seeing the words difficult conversations if you are. Not yet, huh? Not seeing it yet, huh? I might go ahead without my slides and you can listen to my voice because I am not sure why it's not sharing. You guys are not seeing it, right?
Not yet.
Okay. Let me try one more thing, and then if not, we'll go on just with my face and voice without the sharing. Try one more thing. So I'm on share screen, and I am. Are you seeing it now?
Yes.
Yay. Okay, excellent. So I again want to sort of credit the group overall at Kaiser Permanente, and we're also really sharing this with our medical students as well. So there are, we started to talk a lot about the virtual connections and difficult conversations. And so some of the landmines that we're seeing in 2022 post-COVID in office as well as in virtual connections is that we can have a harder time connecting literally physically as well as emotionally. We're really, it's difficult in this day and age for many of us in our country, and I believe in yours as well, to rely on non-physician support to help us connect, again, physically and emotionally with our patients. And then trust and respect are really getting eroded in healthcare in 2022. What we know is that 15% in the US, 15% of patient encounters are described as difficult. And when we look at our patient volumes, that's probably at least 1 to 2 per full or half day clinic. And that can be really draining for all of us. We know that there can be bias from patients toward physicians, and that it gets amplified with younger age, with ethnicity, with gender differences, with race differences, religious differences, weight. So if physicians are overweight, there can be bias, political views. In the US, if somebody has an accent from outside of the US, as well as sexual orientation. So, you know, I think looking at ourselves and understanding which of these things we're bringing into the room. For me, for instance, I walk in and I am a woman, and all of a sudden some of the cards are already stacked against me. I no longer have younger age there, however. So what we know within my medical group at Kaiser Permanente is that microaggressions, harassment, and bullying towards physicians are more common for women, underrepresented minorities, and women in male-dominated fields. So the women in orthopedics for sure. We also know that we have left paternalistic medicine really in the past. So we used to have this way, I think, of withholding bad news. Doctors used to lead the conversations. Doctors told the patients what to do. There was a respect, but there was a fear. And we know that compliance in that kind of paternalistic driven way, at least in the US, really was noted to go down in this kind of generation. And then there's also this challenge of a shift toward consumerism. And in the US, we're dealing with this issue of patients not being called patients, but being called customers or members. And so managing ourselves and self-protecting to think about what are the hot buttons, what are the microaggressions, what are the threats that we're worried about from our patients that may keep us from connecting in a healthy way. So what are hot buttons? So sometimes the conversation can become emotionally or intellectually hijacked. And then we're no longer in control of really communicating in a healthy and productive way with our patients. So for me and for my groups that I do communication coaching with, really spend a lot of time on thinking about what triggers me, what triggers us, what are the things that the patients in the room are saying that get my heart rate up, that get my breath a little bit higher, so that I'm no longer really calmly and kindly focusing on the issue at hand. So there are some ways that patients come after us in this day and age, and it's so sad, but it's true. Did they come after values, professionalism, skills, experience, age, gender, time? We're running late. We're always running late, right? And when we walk in the room and we have somebody who is really upset about us running late, it's so hard to recover and really come into a space of acknowledging that and then moving forward to really take care of them. And that's why that can really compound. And then boundaries. I think that it used to be my father was an orthopedic surgeon, and boundaries were very, very clear in his day and age. People ask me inappropriate questions all the time, and it can be very triggering. So we know that the hot buttons can push us to disconnect, to demean, to dismiss, and to really sink below ourselves. And if we're not really careful about what those are. So the opportunity to take a breath, challenge, choose, and really just be mindful of what's happening in my own space, in our own spaces that's happening, so that we can go back and still take care of this patient or this patient's child or this or the parent, whoever it is in the room who's the patient, to really keep them at the center, even though somebody may be coming at us. So we contribute too, as physicians. We are allowed to be human, and some of us carry anxiety and depression. Some of us, all of us, carry exhaustion and overload. Guess what? We all have personal and family health issues, sleep deprivation and insecurity. So that can really marry for this inability to giving the patient what they need. And there's insurmountable patient contributors too. Sometimes it's just not somebody in the room who can really be brought to a good resolution with this difficult conversation. If they're mentally ill, if they're addicted, if they're culturally mismatched and there's just no getting around it, sometimes there is a man in the room who is just culturally not willing or able to accept medical care from a woman. I need to recognize that and just not try and force the issue if it's not an emergency. Chronic pain, finances, literacy, and then just abuse. So all those insurmountable patient contributors, I think, need to be acknowledged. So this is our little model that I think has gone a long way for us of negotiating for success when we've got a difficult conversation. And that is coming into the room, acknowledging whatever it is the patient's asking for, even if it's completely absurd and never going to happen, but deferring it. So if the patient says to me, my knee hurts, I would like it replaced, but they don't have any arthritis, is a great example of something that's absurd. But what I can choose to do is say, I acknowledge that you would like your knee replaced. I hear that that's what you would like. Let's talk about some other things. And then going into strengthening relationship, defining what they're really looking for, which is an answer for their pain, educating, identifying and reviewing options, and then leading to agreement. So I think that also to recognize the barriers to this is a remembrance of the microaggression and what that is, and recognizing how to keep it from being the landmine in the room. So it's a statement, action, or incident regarded as an instance of indirect, subtle, or unintentional discrimination against members of a marginalized group, such as a racial or ethnic minority. It's a lot of words, but it can go both ways. And so if the patient's being a microaggressor against the physician, that can be a landmine in the room. And then also let's remember, sometimes patients are experiencing microaggressions from other people in our health field that can get in the middle of these difficult conversations. So I want to go back to the model and sort of re-recognize that, and then hand back over, because I think I've gone beyond my little 10 minutes, but just to remind this model, it's the acknowledge of whatever the ask is and being willing to defer it while we strengthen our relationship, define what they're really asking for, have an opportunity.
Sorry to interrupt. We are not able to see your slides. So can you go back to the slides which you are mentioning.
Oh, you're not able to see it anymore.
We are able to see slides. Yes, exactly. Now it's negotiation for success. Please.
Yes.
Please
Okay.
continue.
I'm going to leave that one up there.
I'm disturbing you, Jane. You need to go into full screen mode at the bottom.
There we go. You guys can see it again?
No, not yet. You need to go and it doesn't open up. You need to open the whole slide or go up to slideshow and please start it.
So it is now on full screen.
No, not yet, ma'am.
So it was, can you see me now?
We
Can you see it on the not full screen?
No, ma'am. You need to go to full screen at the bottom, right at the bottom, and double click on that, please.
So were you guys seeing them before or no?
No, we weren't.
Okay. I can't, unfortunately, I'm sorry. I was just in a meeting a half hour ago and it was sharing and I don't know how to make it share right now. Let's try stop and start one more time. And you know what's probably easiest? Let me just write that in the chat so that you guys can take a look at that and then we can kind of open back up for discussion. Let me just do this. You guys see in the chat there, that's the model that I'm discussing and that I would love to open up for some discussion for you guys.
Yeah, sure. We will continue the discussion on this model once we are open for the discussion. So
Jen can continue with her presentation. All you need to do is just share screen and open the slideshow and you will go full
Yeah,
screen.
I've done that and I don't know why it is not, it's not cooperating. As I said, I was on a Teams meeting just before this, sharing my screen successfully, but it's not doing it. I'm going to try it one more time.
Yeah, you can try one more time.
Do you guys see it now? Because it says that it's sharing my screen. Do you guys see it or no?
Yes, we can see your screen. Yes, now
Now
you're full
it's on.
screen.
Now it's on.
Okay.
This is going live, Jen, and that is the reason we want the benefit to go to all the viewers across India.
Yeah, got it. So there is the model of the negotiating for success. Are you guys seeing that? So I think that this is a good point to stop and open for discussion on what people are seeing, use other people's expertise, and let's really unpack this this ability to have this difficult conversation and talk about these barriers. What is the group, how is it resonating with you when I talk about these barriers of the microaggressions and the language and the sort of status that healthcare is going into in this day and age? Are you guys feeling that?
yeah, some of the challenges we face, but the more important problem is when it comes to a difficult diagnosis or a difficult condition like a complication, or telling a condition with a poor prognosis. This is where we really find it difficult how to communicate. And at that point, we feel that probably our conventional communication skill is not adequate.
I think importantly also, I think like Jen was saying, is the current day sort of a patient demographics. In a sense, they come semi-educated looking at the Google and all the information sometimes. And then, they start the conversation with as if that I know all and you tell me what is right. It is for us also to shut down our ego sometimes, and depends upon how much time we are able to devote to each person. Suppose you are having your calendar loaded with about 20, 30 appointments for the day, you hardly have much time. So even if you give time, what happens is when they start off rattling without being structured, that sometimes irritates you, but we need to keep quiet and then interject at the appropriate time. That is one sort of an aspect. Second is the level of understanding demographically, some other areas they come, it takes a while for them to grasp what you're saying. So these are sometimes could be a small issue from that angle. Besides what Dr. Dhiren mentions, those are situations where we find either the diagnostic or sudden turn of events to be communicated to the family, or probably sometimes the unexpected situations that arise. That could potentially be this. But commonly what I face more and more these days is that elderly people coming up and the children are well versed and they come with some half knowledge and they start literally sometimes looks like the language challenges you, though they don't mean it actually. I think it probably calls for patience from our side.
Surya, if I may add, actually a lot of us face, the scenario is quite different in the private sector and the public sector. This is something we have not been trained for, the concept of privacy, your own space.
Exactly.
So especially when you're in a public sector institution, seeing the crowds that all of us have, we don't have dedicated spaces where you can actually have difficult conversations with patients. And it's quite challenging with 17 people, over your shoulder, 7 over theirs, trying to hold a conversation, establishing a one-to-one connect with the patient. And this is something that we need to train our young colleagues in, because we have also all learned by experience that you need to respect that other person. I mean, yes, you are the doctor, maybe you are the provider, they are the receiver, but there is a connect that needs to be established. And that's what Jen actually suggested. That one, we need to, and all of us have faced this shameful, but yes, we actually talk in patients in terms of their disease. In a public institute, how many of us know the patient's detail, the names, the actual whereabouts of the patient? So we have not even tried to establish a connect with the patient on that aspect. So I think this is something we need to be aware of, that we need to be able to actually know a little bit about the patient, talk in a language that they understand, which you rightly said, in a place that provides a semblance of privacy, at least where we can have a difficult conversation.
Yes,
I agree.
I think another aspect of public versus private sector difference is I actually made a shift from being a private practice physician to working with Kaiser Permanente. And when I had patients that were driving and flying and coming to see me as Jennifer Weiss, the trust that they walk in with versus the people that perhaps don't know who I am and are just coming because Kaiser said I was their doctor. And the way that I walk into the room and what I'm starting with is very different. And so I can be the same person with the same expertise, but walking into two different rooms, I'm set up in two entirely different ways. And I am certainly not going to walk in and say, I know exactly what I'm talking about and you should trust me. That's not the way to establish the trust. But I think that in the sector that you're talking about with the public sector, and there's many people waiting and the facility may not be as nice, and just that trust of people starts off at a much lower level, and the work we have to do to get them on board, I think, can be so much harder on us. What do you guys think about that?
Yeah. So we agree that the trust and the mutual respect, needs to be gained back. That is very important, So, taking this conversation ahead, we would also like to understand from the other panelists as to various difficult situations and the difficult conversation situations that they had come across. So my first question would go to Dr. Ram Chadha. If he could narrate an incident, or he could come up with some incident where he had to, how did he manage a difficult conversation with a patient?
Well, I go back about 18 years, and I go back to a small little story that I would share. I took a patient in for a cervical spine surgery. He had mid-cervical tuberculosis, which is very common in our country. And he had an incomplete spastic quadriparesis. He was a walker, but he was falling off. And he was a young, recently married gentleman working as a travel agent in India. And he had these parents for whom he was everything and who were very concerned about him, but were in that era or age where even tuberculosis was regarded as a stigma. And I'm talking of 18 years back, which is fairly recent in a country like India, but they were worried and concerned. And I walked them through the entire counseling that this gentleman would need surgery and it needs to come out and he's weak and the possibility of him improving is significant and we need to do it early. And having done all that, I'd also slipped in that it may take a long time for him to improve. I was 18 years younger. Today, I would have probably counseled him more aggressively of the possibility of an immediate post-operative neurological shutdown, which maybe at that stage in my career, I did not give it that importance. And lo and behold, I do the surgery, begin at 8, and at 12 noon, I realized that I have a patient who's woken up and he's shut down completely. And that was something which hit me very, very hard. This was the pre-neuromonitoring era. Today we have neuromonitoring, so we have certain ways to circumvent such a situation. And I think I went through a very, very difficult time. I came out, I spoke to them, and somewhere within my mind, I felt that maybe I have to have a second look, which is get in there and re-look at the implant, take it out, maybe shorten the graft and put it back. So it was double-edged. One is sharing the unfortunate situation, but also consenting them for a re-look immediately. Now, we are in a situation where if you go evidence-based, you would say, okay, get the patient out, put him into a CT scan or an MRI, confirm whether a relook is warranted, justify the relook, and then get him in. But there are times when the patient is in the OR and something within you says that, listen, I can do that, but I might as well go down. I have to just take 5 minutes, open that thing and get it out. So I'd want to share with them that he's shut down, and second, consent for him to get in and go in again. Now, what would they consent me for? They would consent me for with the hope, the belief, and the trust that maybe a second intervention would undo what the first had done. This was probably the most difficult. And well, lo and behold, I went in again. I did find that maybe my graft could be sort of shaved off a bit. I shaved it off. Then I impaled my bone graft to my plate with additional screws so that it would never touch the theca. Closed. And believe me, I spent the next 24 hours in the intensive care waiting for this young man to just wriggle his toes. And yes, he did. So it was not just a conversation, but it was a huge interaction with the parents outside who were concerned, and I was on the inside. Taught me a lot of things. But as I look at it today, how would I do it? Well, I'd counsel them much more. If you've said the worst, even if the worst happens, you can face it. But you've not really shared the worst in black and white, and if it happens, it hits you hard. That's all that I have to say right now.
Thank you, Dr. Ram. I think other panelists also would have faced a very similar situation. So if Dr. Surya Narayan would like to narrate any situation that he would have faced, which had a difficult conversation to have.
Oh yeah, I think something on the similar lines, but not, I was operating in another city with another close friend of mine. And basically this was infected hip replacement, which had to be explanted. And this was in Hyderabad, the close friend was there. It was totally a mess up. So we started removing from the outside, but I thought initially, and this person was from one of the African countries, in addition to do it. But fortunately, they knew English. And when we tried to take it out, the cement plug, what we say, was into the hemipelvis, into it in the lesser pelvis. So there was always a concern that there may be some adhesions when you take out and there's a major venous ooze which could come in. The angiography was not done, and that was the biggest mistake that was done by them. And I had no control because I reached in the morning. And lo and behold, when we just took the cup out, it started bleeding and oozing. But immediately I recognized, asked for vascular help, and we got them to open from the intrapelvic side. So, and we tried to arrest the bleed first with the tamponade. To further proceed, the dilemma was how to tell them, because the options were either to completely just keep it with the pack and leave it and come back, or take him to the angio suite and then identify the bleeder and see if we can embolize. That would have been much less morbid. But you can't just take the anesthetized patient out without telling the relative on this case. So we thought a lot about it. The patient was, sinking and borderline in terms of the vitals, but was transfused, stabilized a little bit. So both the gentlemen who had my colleague who was the primary physician on the scene and me only as a help. So we deliberated on that immediately, and we said the best is to get somebody out outside the operating room and tell them what exactly it is and what we propose to do. I said, put everything threadbare to them completely. And we told them, told the brother, for again, the language was not an issue. So they just narrated that this is what has happened. This is the bleed that has happened. Very difficult. This is not one single vessel. You may need to embolize, and there is a procedure to be done in the angio suite. And that's why we are wheeling. At this time, you are stable, he's stable. And I think we should get through with this, hopefully. And the vascular surgeon was there on hand to say that this is going to be handled by the vascular people. And he was there to fortify and push our own thinking to him. And the patient condescended. So that way the consent was there with us. The procedure was fully explained to him, what is going to be done. And we said he can in fact come and maybe watch the screen in the angio suite to what is happening. Unfortunately, by evening, everything sort of settled down after they plugged all the 3 bleeders. Yes, it was difficult at that time because you're drowning, because he's vitally from the vital parameters moving up and down. But sometimes you feel that putting all the cards very straightforward probably takes a lot of the load and the stress on you, and focus on the issue at hand rather than going how to tell them or what to tell them.
Yeah, thank you, Pichai. Now, before I ask Jen about her thoughts, I would like to ask Dr. Matthew Varghese. Dr. Matthew, have you come across a similar situation? And if yes, I'm sure that from your vast experience, there must be such incident. But I would like to focus more on how do you deal with these incidents when they happen. So can you tell something about that? And after that, we will have the thoughts of Jen on this. Yeah, over to you, Matthew.
Thank you. Thank you. Sorry, I was keeping it off video because my connection is unstable. So I may need to switch off the video anytime. Apologize for that. Thank you, Dhiren. Yes, of course, not one. There have been several episodes where I have had real challenging conversations. And as mentioned before, today patients come with all kinds of expectations, especially if you're working in a situation where, particularly in India, where insurance is not covering your expenses, it's out-of-pocket expenses. So that becomes an additional burden, and their expectation goes up because they are spending hard-earned money, and therefore it has to give you the return in the best possible in the minimum expense. So there are 2 situations. So I'll probably give 2 quick examples, not too much time. One has to do with consent. This was about 15 years back. Child with arthrogryposis, very difficult to treat and correct. She had one side corrected partially, but residual equinus was still persistent. And the other side, I had put in Joshi's external stabilization system differential destruction, and was ready for removal. Deformity had been corrected, and I was interacting very well with the parents, no problem. So I always used to remove them under operation theater conditions, and I told them under GA, we'll remove this and put in a cast. But I had also told the father, the other side, there's the residual equinus. We should do it in otomy, and we'll do it when the patient is under anesthesia for removal. And I was in the theater, I was busy. So my resident and my other team members, they put up the case, and they said, sir, the patient is ready. So I moved in from one theater to the other theater, and I removed the fixator, and I saw there is a residual equinus, and I already told the father about it. And I did the tenotomy and put casts in both sides and went to the next case. I didn't come out because by the time the anesthetist had anesthetized the other case. So I went to the other theater. I didn't come out. After about 10 minutes, the sister comes. Sir, the code violet has been announced. Your case, which was operated, the relatives are saying that you've operated on the wrong side. I said, no, it is just not possible. I have not operated on any wrong side, and that's a clubfoot. I can't make a difference. It's visible. Equinus is visible. I can't make a mistake there. So then I called for the file. Apparently, the consent was only for removal of the fixator and not for the tenotomy on the opposite side. So when I went out to find out, the father was not there. The person who was making the noise was the uncle. I had never met him. I'd never talked to him. He was the one. The father was never there on that day. He had some work, so he hadn't come. So the uncle was there and he saw the plaster was there on the opposite side. And you operated on the side which did not have to be operated, and you was gathering all the other relatives. And there was a huge crowd outside the operation theater. Oh, disaster. So then I specifically told him that this was only a tenotomy. This was needed. I can't make a mistake here. Yes, I agree. I made a mistake. That we made a mistake. We didn't take a separate consent for that. And I'm sorry about it, but she needs it. Believe me, we have not done any incision. We have not done any other procedure on it, just a tenotomy to correct the deformity that she had residual. He was not very easily pacified, but anyway, child was transferred and went back. Next day, the father came. He said, Dr. Saab, you had told us about it, but you didn't tell us that you're going to do it today. I said, she was under anesthesia, that was it. So I kept my cool all along, kept pacifying them. Took care, nothing wrong. Please, I'll be there with the child, right? So it's my responsibility. I'll take care. Right till her foot is corrected. And 3 weeks down the line, when the cast was to be changed, my resident said, that patient who had fought was there, is there. Do you want to go? I said, yes, I will deal with it myself. I'll not pass on to somebody else. So I went to the plaster room. The father was there and I showed him, look at how does it look? Yeah, Dr. Saab, that looks good now. Thank you so much. We are relieved now. We were worried that something wrong has been done. Believe me, this family is 15 years down the line. The girl is in high school. Every birthday she comes and gives candies to my other kids who come to my outpatient. The whole family comes to me for their, I kept my conversation and I was continuously in touch with them. The other quick references, there was a patient for surgery. I have a long list normally, which goes on till midnight, past midnight. So this patient was posted for surgery. I didn't know which room she had got into. She had got into one deluxe room. It's the most expensive room, in my hospital. And around 5 o'clock in the evening, again, sister comes and says, sir, this patient posted for surgery in deluxe room. They're creating a racket. Again, code violation is announced. Crowd is gathering. So we were operating inside. So I came out. I de-scrubbed from the case I was doing, came out, and I tried to talk to them. Yes, we have to get the patient in. We will do it because we have children, many children on the list. We will do the case after that. No, we have been here waiting. So they were really, so I kept my cool. I said, don't worry, we'll take care. We won't leave until her case is done. Every case will be done. Please bear with us. Please understand there are much smaller children. At that time, a smaller child was wheeled out. So they saw the smaller child was there. I said, please believe us. So we got the patient after that. Soon after that, we got the patient in and did the surgery. And by the time I finished that day, it was 2 a.m. in the morning. And at 2 a.m., went to see the patient's relatives. They said, it took so long. Oh, you come so late. Next day morning, early morning, 8 a.m., I was back again in the patient's side, talking to them, finding out all well. By 11 a.m., the mother came back apologizing profusely for the behavior of the father, that he created a noise and created a scene. So just making sure that you're transparent about a mistake that has happened. I said, I'm sorry, our mistake was we didn't take the consent. But the child needed it. We've not done a wrong side operation. That is one side. apologizing, sorry, and proceeding on with the conversation, not treating them because they have been bad with you, because they have been bad with my staff, I be bad with them. No. One anger is not countered by anger. It is countered by being peaceful and, if necessary, apologetic. Why not? Why not? You don't lose anything. And the other family, they thought they had got a deluxe room. They had a right to everything. And on priority. We do give priority, but definitely this child who was younger needed a better timing. That's all.
Yeah, thank you, Matthew. Now, Jane, a quick comments by you for all the three cases. What are your views?
So I think that there's two things to separate. One is the communication with our patients, and then the other is our own feelings and mental health about what has happened. And I believe that the communication with the patients is really the focus of what we're discussing today. And I'm hearing masters at this, right? Masters at putting the ego away and really getting through the situation. And all of the stories ended up with your patients absolutely feeling trust and feeling brought through the situation. But I just think that I would be remiss if I didn't bring up also what's going on in our own heads. And I think that in our health system, we have created a situation called second victim support, which is really peer support and really this ability to call on. I'm a peer supporter, for instance. And so in some situation in which one of my colleagues has had a situation that was nerve-wracking and either a complication or a near complication or what have you, to have the opportunity to put away the patient facing and then just have ourselves with a colleague to be able to debrief, to be able to talk medically if we need to talk medically, or to be able to talk entirely non-medically. So I just want to point that out. And I wonder if the people who shared their stories have some words of wisdom as to how you debriefed and how you got through this mentally. You got your patients through it. How'd you get yourself through it?
Yeah, we will be coming to that point in our interaction in a short while. Before that, I would like to ask Dr. Sundar Suryanarayana about what are the patients-related factors which are responsible for a difficult conversation. Just a quick enumeration of the factors which you consider very important.
From the patient's point of view?
Yeah, the patient's related factors, like the one which we said about the gender difference. The second is about the age difference or the language difference. So what are those factors?
I think one is that there are some who come with that implicit faith completely, and they start the conversation saying, we have been referred and we entirely leave it to you to make the prudent decision to do it. I mean, that puts a huge onus on the surgeon or the physician, because everything, whatever you say, they are ready to accept. And whether we are doing the right thing for the right person, for the person, is an important, very important aspect. And whether we are giving them all the different perspectives and making the right choice. That is one type of the group of patients where you have no difficulty in putting the thing across, but the onus of responsibility to choose the right thing sits on your head. Second thing is the pattern of people who come with some information and then they are a little sort of, whatever you say, they're a little doubtful. There are a little group of people who come. I came thinking, because all others told you always don't suggest any surgery or intervention, so I want a medical management altogether. So their mindset is already prefixed that when you come to this place, probably this person, just because somebody else had that you will give a medical management, though in all probability she was in a stage 4 of arthrosis or whatever, and she only requires surgical correction. So it is then comes for us to say, I cannot at the same time tell them, no, you need surgery and forget about it. We need to temper it down the way we put it across. So here the important aspect is how we put across the issue, that not all are alike. and that different situations demand different remedies. And that's how then we start tempering the conversation, slightly putting across the whole spectrum. It takes a while, but that's what. Then the final group is there who are, like I said in the beginning, who are coming with the new knowledge. I mean, they have it, but not so appropriate. But nevertheless, I think it is a right for every patient or the close member of the family to have all the information. And in fact, it is much easier to handle these people. But unfortunately, sometimes there may be a mix-up, and it is for us to listen to whatever they have to say, and then make the correctives and deviate and say, no, this may not be the most appropriate way to look at things, rather than confronting them to say that don't try to teach me, I know what I do. This is how we look at it. So I think in all the ways, I think patience is a huge virtue. Give the first couple of minutes for them to let out, even though it may be irrelevant. Sometimes, like Jen said, let them talk it out, and then come back and pick up at the right spot, and then you take over. So the point of taking over the conversation first, and then getting into your questions, or they trust the results and the reports. So my standard answer to them is, I don't look at any of the investigations, not the MRI, unless I've seen the patient, because MRI is very sensitive, or the scans are sensitive. They give too much information, but unless I know what the problem is, I can't interpret this. So then that they take up, then they keep quiet, then you can take the history. So I think if we have the capacity to identify what pattern or what quality of the person is as he walks into your room, I think that makes a big difference.
Yeah, thank you, Dr. Suri. Like, that's a very important point. Now, I would like to ask Dr. Ajay Puri, like Dr. Pichai said about a lot of patient-related factors, but there must be some issues with us also. So what are those doctors or the physicians-related issues which you consider important in difficult conversation? We discussed that the ego is one of the things.
Correct.
Yeah.
So one is, I think, and Surya correctly mentioned it, that you need to know what the patient knows, and then you need to add on it. And the information that you have to give is in very, very small chunks. We tend to sort of become verbose, try and explain things in a technical manner, which is very challenging for a patient. Now, for the others who are unaware, I am an oncologist. So I deal with cancer. I unfortunately seem to have much more opportunities to have difficult conversations than all of you will combined, purely because of the nature of the disease that I deal with. So a patient coming to a cancer hospital is anyway stressed. Even if you diagnose him as no cancer, the stress levels are through the roof. So if we try and give too much information, nothing is going to permeate it. You have to give your information in small chunks. And also, you may have to give the same information again and again. You have to be able to maintain your cool. There is no sense getting irritated because you are repeating the same thing, may not be to the patient, maybe to 3 different relatives at different times, because this is something where the family comes, as a group, as a support group. So you have to keep your patients, give your information in small chunks. And the other thing which I would just like to add to Surya is one of the most challenging and difficult complications, and because most of us are senior colleagues here, is patients who come to you with the complications of other surgeons. And that is something that we have to be very careful when we are talking to them and discussing, because they are aware that there is a complication. They are also looking for someone to blame. And while accepting the fact that, yes, there may have been an issue, you have to be very careful how you modulate your conversation. And the best way to be look on solutions rather than try and address what happened, what could have happened, what may have happened. No. This is a scenario today. Let's look at how we can best address it so that you return back to the best functional status that we can do. So this is something that we need to be aware of, and one of the most challenging conversations that we may have had to have with patients.
Yeah, thank you, Professor Puri. Now, Dr. Ram, I would like to ask, like Dr. Suri said about the patient-related factors, Dr. Ajay said about the doctors-related factors. What are the other factors which are related to environment? Something like you are in a teaching hospital and there are 15 people along with you in the rounds. So how do you communicate efficiently in such scenario?
Well, I'll be very frank. There are two aspects to difficult situations or conversations, and Ajay deals with probably the most challenging because he has people who are in a sinister state where they may not be there tomorrow because you're dealing with an oncology setup. So it's between life and death. But when I look back, I also feel that at the end of it, there is an end point. Okay. There are some guys who don't become surgical oncologists, they become spine surgeons. So what they achieve is they achieve making very unhappy people less unhappy for the rest of their lives, which means that a spine surgical patient remains a patient for a majority portion of his or her life. Now, these patients are a lot dependent on the environment, as I'm coming to. I look at a spine patient's treatment in 3 steps. One, when he reaches out to you, he comes with a lot of hope. This hope comes from what he's heard about you. Like they've heard about Surya Narayan, he does not offer surgery upfront, and they come to him for a non-surgical option. And Surya finds it difficult to convey to them that they do need surgery. And I love that because I also find a lot of people reaching out to me because I also offer non-surgical options for spine care to begin with in majority of my situations. But then there are outliers, those who need surgery when you see them. So when you've heard them out, as Surya does, you sit down and ask them one question. And I do it every time when I have this clear-cut surgical patient sitting in front of me, and it's maybe once or twice in a day when I've seen 20 patients. And I tell them, do you want to hear what you want to hear, or do you want to hear the truth? So they've come to you with a lot of hope. That hope then next gets converted into something called belief. Now, what is belief? Belief is what gets into them when they're sitting in that clinic outside. You're talking about these 15, 20, 30 people around. You see a lot of people sitting out in the clinic, and this happens in large setups. I'm not looking at a small setup where it's a private clinic where you get in one and get out, where probably having conversations is much easier. But this is a setup where there are other people having similar problems seated outside. And mind you, a lot of your non-surgical patients are the ones who get you surgical patients. They believe that you treat them adequately non-surgically, and you would say surgery only when it's really necessary, and that's the way they come. But that comes from that peer group which is sitting outside discussing, and they discuss what they discuss behind your back is actually the truth. So they convey a lot. So that's what happens outside. And then finally, when they come into your room, that's where that hope and belief gets converted to trust. And that trust comes only when they believe that you would do this on your own child, your own wife, your own mother. That's when they give in to consenting to your surgery. And that will only happen when all the doubt, the skepticism, which the investigations they carry, my patients carry MRIs that they've had for years. They carry reports of electrophysiology that they've had for years. They carry X-rays. They carry 10 to 12 opinions. And then they come into your room. It needs to be converted. That will only happen when that doubt, skepticism, suspense, all that which is based purely on investigations, like a policeman, gets converted into faith, trust, belief. So this dichotomy is conversation. That is where we have to go from getting into a situation which was based purely on investigation, which is skepticism, doubt, to trust. They are opposites. And we are the only profession where we have to bridge this gap, whether it is before the surgery or after when things go wrong, where trust again goes back to doubt. And that's where we are in that flux, and we have to just keep talking, and more than that, keep listening. I strongly believe just keeping quiet and listening, letting time take its course, it heals.
Therapeutic silence.
Absolutely.
That's
Silence and listen. They are the same letters, L-I-S-T-E-N and S-I-L-E-N-T. They are the same set of letters. Just practice it. That's all that I do.
So difficult conversation has a phrase which is known as therapeutic silence. That is a beautiful balance that you have between sustaining hope and maintaining the realistic goals. Thank you, Dr. Ram. I think this comes by practice. This is not something which young orthopedic surgeons can immediately come out. So in a situation where there is need for a difficult conversation, this will require a lot of practice. Moving ahead to another part, the question is directed to Dr. Matthew Varghese. What I would like to know is, how do you feel about a difficult conversation in cases where you have to have a balance between the physical, mental, and the emotional, psychosocial domains of the patient as well as that of the relative?
Well, it's always a challenge in trying to understand what the patient is wanting. Is when I ask them, what are you expecting? I deal with a lot of difficult situations, cerebral palsy children, children with muscular dystrophies, patients with paraplegia, like Dr. Ramchada. So those are situations where I ask them, what are you expecting? When they tell me they want to be normal, I said, I'm sorry, I can't make you normal. I can only make you better. I can only make your situation better than what you're in and improve upon it. And so that this child or this patient gets the maximum and the optimum benefit from whatever strengths that the child has. So my job is to ensure that he gets the best and the optimum, outcome from whatever I can do in his life. So what I can do is to make sure that whatever barriers I see, I take care of. Beyond that, I can't make him normal. That has to be very clear. I still remember there are some situations. There's a patient who was paraplegic, 74-year-old lady, going in for surgery. Anesthesia was given. Soon after anesthesia, she arrested. 74-year-old lady, wife of a judge, she arrested. And the anesthesiologist told me, please inform the husband that she's arrested. And they were resuscitating. And my heart sank. Here is this judge. I have to go and tell him that his wife has had a cardiac arrest on the table. So he was 76, he's a retired judge. And I went outside with a heavy heart, expecting the worst from him. So I went to him and explained to him that, look, this is what has happened. We have not put our knife on the patient. He's had an arrest and we are trying our best. So he looked at me. You try your best, sir. Don't give up. So he was with me and I had great relief on seeing this. So I was terrified to go and address him, and he was actually reassuring. So the reverse can also happen. Some of the patients can be difficult, but some of the patients can also be very, very supportive. And fortunately, we were able to revive her. Then the question came, anesthesiologist said, she was intubated. No, we won't operate her now. So I said, she's already anesthetized. She's already paraplegic. She's 74. What if you bring her out? She'll go again paraplegic forever. She's not going to recover. So no, I think you go and talk to the husband. So again, went back to the husband. No, patient is intubated, anesthetized, revived. What do you want us to do? So again, he looked at me. I mean, fascinating. This wise man was a judge. He said he had full trust from what I understood subsequently. He said, Dr. Saab, go ahead. We hope for the best, but prepare for the worst. Profound statement. Hope for the best, but prepare for the worst. I said, okay, sir, we'll go ahead and do it. So we went ahead and did the surgery, and about 2 months down the line, she had recovered sufficiently enough to be able to walk again. So it's not always that your challenge is born only by you. The patients can also be supportive. And this was a very supportive patient. So we have both sides of the coin, and can be difficult because then it's very, very, very challenging. So your main thing would be transparent with the patient, right across. Be transparent, tell the truth, but as was said in Pandora's box, don't take away the hope completely. Leave a little window for hope. Ajay Puri, I think, would have the maximum opportunity. He gave the very, 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 very nice way of putting it and give it in small, blocks. So divide it into blocks. So maybe you need to do that, and always have time. Don't tell the patient, I don't have the time. No. And this is something I keep telling my and training my residents on. You have to have. In fact, I always say, I don't wear a watch and I don't work to a clock. So they say, no, you're getting, I said, don't worry. I have all the time for you. And that assures them so much, reassures them so much. So, okay, this doctor has all the time. And say, Dr. Saab, you're the first one to give us time. You're the first one. So that immediately gives them, okay, he has time for us. He will do what is correct because he has time for us. So that trust I'm building in my conversation, in my interaction, not just by words, but also by my actions. So you have to walk the talk. The patient sees you, what you're doing, they interact with you, they will be with you. Majority of my patients are with the most difficult situations.
Thank you, Dr. Matthews. I think that has given a lot of perspective about various difficult situations and challenges that can be addressed by our young orthopedic surgeons, those who are watching this show. Sir, the question now next is directed to Dr. Ajay Puri. We believe that the conversation and communication has to be very honest. Simultaneously, it has to be productive, relevant, and it should be emotionally safe. Now, the question to you is, since you are in an ecosystem where balancing the entire scenario is very difficult, how do you go about it?
So I think Matthew's already taken half of what I was going to say. The biggest problem is complications or anxiety arises when there are unmet expectations. If you are unrealistic when you're talking to the patient initially of what is likely to be achieved, then there is going to be anxiety. It's the same with us. If you see something in an advertising portal and you actually go to the shop and it's half of what you've been told it is, there is going to be anxiety. So you have to be upfront, you have to be realistic, but as Matthew said, you don't take away all hope. It's like when we are told that you are supposed to tell a patient every possible complication that can occur. You and I both know that if we list out every possible complication, nobody, including us, will ever consent to surgery. So you have to strike the realistic balance between what is your goal, what you are trying to achieve, and what is most likely possible. And once you establish this balance and this trust with the patient, your life is a lot easier. Complications occur with all of us. And at least personally, I have seen, and every one of us has experienced, that if you are honest with the patient, you are upfront, even if it is your own complication, the majority of them are willing to be part of the journey as to how to overcome it. It is when we start becoming defensive, aggressive, when we realize that every complication is not negligence, it occurs. That is the way our profession is. Our profession is not science, 1 + 1 is going to be equal to 2. There are variables. We have discussed with the patient earlier, and you acknowledge the fact that this is what happened. It was likely. Let's see how we can address it. That is much easier. And I think the other issue is there are patients who are doubting Thomases when they come to you in the beginning. And you should have no hesitation in recommending second opinions. We do that very actively. That this is what I believe, but you may have an alternative. If you are not convinced, please, there are other experts. These are the names, 2 or 3. Please feel free to consult them. And then go with a doctor whom you have belief in. It need not be that what I am saying is correct, what ABC is saying correct. You can balance on your own, but these are the alternative options you can consult. So we have to be quite open about that. And I think majority of the issues then resolve with conversation, and we are unlikely to face really very troublesome situations if we follow these basic norms.
Yeah, thank you, Dr. Puri. Now, both Matthew and Ajay, they have given a very good strategies how we can deal with this difficult conversation. Now, I will ask the remaining three panelists about what are their strategies. Like, is it the same one or what is the difference? Just tell us the difference which you would like to highlight. Yeah, over to you, Dr. Pichai. Yeah, please unmute yourself, sir.
Both Dr. Ajay and Dr. Matthew have covered quite a few bases. What I think being upfront, I think, is the biggest important thing. I think and then develop a trust. Basically, they come with some of the patients come with preformed opinions. Some are there who are open about the whole thing, but it is for us to probably structure the whole thing what we want to put across. And give space both to the patient and so that they can come up with what their thoughts are. I think the third point is give the options. Rather than saying you have to be doing this, if you give all the options, possible options with the outcome possibilities, one probably, in terms of longevity, in terms of survival, in terms of recurrence, in terms of complications, I think we have to also probably gauge the absorption capacity of the patient, how much they are going to take. So best is to put all the cards, and in my considered opinion, probably I would go for this. Like Ajay said, I think I have again no hesitation. I say this is what I feel. You can probably have another opinion elsewhere so that you are comfortable and finally settle down to where you are most comfortable, any physician or surgeon. They naturally then they tend to appreciate that point. So I think they need to have a good understanding of all what the options are. Like in oncosurgery, probably there's only one or two, not many. But in most of the other sort of degenerative disorders and many other adult situations, that could be many options. And the patient should be aware of it. What are the pros and what are the cons?
Okay, thank you. So now, like everyone is saying about that we need to have a trust, or the patients need to have a trust. The way we look at the current practice scenario in India, there are a lot of things, lot of factors which is responsible for reducing the trust in doctors. So, Dr. Ram, what are your strategies for managing or dealing with such conversation?
Well, I look at it that the trust deficiency, the finger points towards us. And I am willing to stick my neck out and say that. There are two words in English. One is called humility and the other is called hubris. Hubris is an element of ego which develops, and if you look at it as an anagram, like silent and listen, ego, if you just look at it as an acronym, it's ejecting God out. Now, I'm not saying you have to be a religious person, but you have to believe that there is something beyond us. The day you believe that you are just an instrument of a much larger force, you will speak the truth. The day you believe that you are the force or the source, hubris will creep in, and then that is where ego is the key to everything that goes wrong. So I strongly believe that as long as you believe that you are not a doer, you're actually a non-doer, you're just a catalyst, and your conversation should convey that, things will work in your favor, because anything that you do is going to be more than what the other person expected. So I always undermine the expectations. I strongly believe that the patient should, at the end of the day, feel better. And in our country, we don't have to just undermine the expectation. We have to also undermine the expenditure, because out-of-pocket expense is a major issue in our country. So if I believe my surgery is going to take me 3 hours, I tell them it's going to take 5 hours and come out in 3.5. Makes them happy. If I feel that my surgery is going to cost them 2 lakh Indian rupees, I tell them it's going to cost them 3 lakh Indian rupees, and they then get a bill of 2 lakhs. If I tell them that it's going to be It's why my return to function is going to be 3 months. I tell them return to function is going to be 5 months or 6 months, and they feel better at 3 months. This is very much an Indian attitude. I hope it's not worldwide, but it's very much an Indian attitude. You have to always promise less than you can deliver. And that's the integral part of a good conversation. And that's all that you need. So keep yourself down, keep yourself firmly on the ground. And I don't think that's very difficult. Just be human. That's all.
Okay, thank you. Jen, I would like to ask, like you heard the experts from India about saying different strategies for dealing with the difficult conversation. What are the major differences which you feel in your practice? Because the practice in USA and India are very different. So what are the difference which you would like to say or pinpoint? We're not able to hear you.
Unmute your iPhone. Yeah.
Can you hear me now? So,
Yes.
yeah.
You
So one of the
There's an
important
echo. Sheila,
pieces, I
please
believe,
mute Yeah, fine.
one of the, can you hear me now?
Yes.
Okay. One of the important pieces, I believe, is actually also in the team approach and in developing trust. I'm going to call out in the US, we know that women are only 6% of orthopedic surgeons. I'm not sure in India what that percentage is. And the teamwork of the playing up our team, of our rising up our teammates has become really important as well. So from the front desk to the space in the office to the second opinions. One of the things I think that's really important is the naming and continuing to name physicians who are doctors. One of our issues in our country is that sometimes, sadly, people will call women by first names and men by doctor. And my partners make a really big deal of always referring to me as Dr. Weiss, probably more than they do for one another, so that patients can understand and gain some respect. So I think that these sort of team aspects of talking one another up is very important. And I'll also say that I love what Dr. Chadha was talking about with the humility and the lack of hubris. I also will say that that is tougher for people who are underrepresented minorities in our space, for women, and for younger surgeons. So we talked a little bit about how the younger surgeons might have trouble with that silence, with that comfort, with that experience, because they don't have it. And I think that recognizing that the different approaches of how do you avoid hubris when you, and also how do you continue to have some sense of reassurance and confidence without it becoming overbearing. And so I think that for us, we do a lot of work with coaching about, you know what, even if you're not comfortable, this is how you can stay silent, and this is how you can breathe, and this is how you can hear that person in front of you. So I think those are all pieces. And then just the healthcare environment in general of the churning patients. And I think it was Dr. Varghese that said that you don't wear a watch. If I run late in my clinic, oh my goodness, every patient that I'm about to see loses trust in me. And so that balancing act can be really tricky. And so for us, we're actually maybe doing a little bit of the opposite of, I'm so sorry that I have these only 15 minutes for you right now, but we're going to come together again. Perhaps I'll need to call you after hours to catch right back up. But these strategies to acknowledge the churning and the volume, I think, are important. So I think those are some nuances that we're noticing in the US, if that's helpful.
Thank you, Jennifer. Those were good insights from United States. In the final aspect of the whole difficult and challenging conversation. Since this is a communication challenge, I would like to ask Dr. Ajay Puri and Dr. Sunira, and both one after another. They are working in an institutes where they would be having young orthopods who would be also there and who are not much trained, because this has to come by practice. So how do you communicate with your team and how do you coach them as to handling these difficult situations? First is to Dr. Ajay Puri, and then Dr. Surya Narayan can answer that.
I think Matthew put it very well. You walk the talk. You cannot preach something and practice something else. So your example is the best sort of teaching tool for the youngsters in your team. They are going to, if you are their sort of role model, they are going to emulate what you do. So that's what you need to do. The other thing, you have to teach them that, this does come by experience. It's not a one size fits all. The same situation for two different patients may need to be addressed differently. So you have to be receptive. You have to, as all of us have said, listen, look at the patient, and then realize how you are going to modulate your conversation. It's not a menu-driven approach that A follows B follows C follows D for every patient. You are going to have to be able to think on your feet. And you need to reinforce this regularly, because this is so-called non-academic teaching. This is not something that is part of their curriculum. This is not something that is part of their course. So this is something you've got to be reinforcing regularly. And I think Jen very correctly mentioned that we are looking at these difficult conversations as being stressful situations for patients. It can be very, very stressful even for the healthcare provider. And, maybe especially in orthopedics, we are all supposed to be macho men, not feel emotional, not get involved in all this. That doesn't hold good any longer. The newer generation has different expectations, a different sort of emotional structure to what maybe we were brought up under. So acknowledging the fact that yes, this can be stressful for the healthcare provider. We have support sources. We have avenues that we can use to address this. We actually in our hospital we have set up a counseling cell which is outside the hospital, because unfortunately, the stigma of seeing a counselor sometimes itself still sort of dissuades people from applying the fact that they need help and going there. So doing that in a relatively anonymous situation where they have the opportunity to just interact with someone outside hospital grounds, but covered by the hospital, can help. So these are things that we need to keep reinforcing, but most important, I feel, is leading by example.
Thank you so much, Dr. Ajay Puri. Dr. Surya Narayan, please.
Yeah, I think Ajay put it beautifully. The thing is, in the private setups, what happens is outpatient area becomes a very private location. So if you crowd around with people, the patients and the clients don't like it. So not too much is possible in that. But on the corollary, on the other side, in the inpatient, when you go on rounds, I think it's a very good point, very good space for them to see. One is the way you have to walk the talk, like Ajay said, absolutely. For example, I learned it 33 years ago in the beginning when I moved to this city in Chennai, that the boss would massage the back of every elderly patient undergoing hip surgery with his own bare hands. And this was just to increase the circulation to avoid bed sore. The next morning, soap and water, and you would massage. So I think we have to learn to use our hands. The patients are immensely happy, comfortable, and you are comfortable that you have done something. So it's like, in today's world, I think there are many other ways to handle that part of it. But like, for example, a physical rehabilitation, rather than saying, tell the therapist to do the flexion, I usually spend a few minutes, at least once or twice over the 2 or 3 days they are there, to do the physical therapy in front. And then the third aspect that always bugs orthopods, especially with the reconstructive surgeries and all, is pain. You dread pain. And patients are very uncomfortable. And when they go, how do you handle when you enter the room, they accost you? The last night has been sleepless, I have been terribly painful. And how do you handle this? So I tell all of them, be emotional about certain aspects. The moment you own the patient and you become emotional about their sensations, your responses become natural. So soft talking, understanding, emotive, and have actions that's done immediately as a response. and then make sure, ascertain that you are using your hands to help the patient. That develops an immense relationship between the patient and the physician and the surgeons, and that goes a long way. And over a time, then you realize how to handle everybody. So, explaining every question or the patient has, not to discard any symptom the patient tends to come. I had loose motions last week. We don't have to say, so what, get the remedy done then and then, so that they also realize that action happens if you are walking in. So do you want to step by step, the residents also realize how to handle these sort of typical situations they are 100% likely to face when they start their own years ahead.
Thank you so much, Dr. Suryanarayan. Very shortly, I would like to know from you, Jennifer, what is the coaching module or the training module that you have for such soft skills, especially communication skills pertaining to challenging conversations?
So a couple of training modules that we have. We start off with some half-day courses in which we actually engage with actors. I'm in Los Angeles, and we have actors come in to play patients. And these actors actually work with us for years, and they're incredible physician advocates. So they can meld into different roles. They can escalate, they can anger, they can poke, and we are able to pause and to really coach people on things like you were talking about, that really pregnant silence and how to gather ourselves and what we're thinking. So that is one piece that is amazing. A second piece that we do is we connect as peer supporters. So if somebody's having trouble with their scores on communication, we get scored on that in our country, and sometimes finances are attached to it. So somebody's challenged, they may be paired up with a supporter and a coach. And then lastly, I'm going next week to be faculty at a course that is 3 days of working with actors and hearing talks and hearing stories from experts like you to share with our physicians who are struggling. And it's physicians only in the room. And I think that that piece is really important. We have the physicians and we have the care actors, and the physicians getting to be in a space where they can connect and discuss the challenges, I think is really important. So that's kind of the overall model of our communications.
Thank you, Jennifer. I think we'll bring an end to this session. To conclude, I hope that most of the orthopedic surgeons who are watching this program today, which was very nicely curated out by Dr. Dhiren, and the questions and then the answers, which were very relevant, the experiences that were shared by us by very senior orthopedic surgeons, Dr. Ajay Puri, Dr. Matthew, Dr. Ram Chedda, Dr. Suri, and then having Jennifer from United States. This has been an extraordinary session. I hope there has been a lot of learning on behalf of Indian Orthopedic Association, and myself and Dr. Dhiren Ganjwala would like to thank all the panelists who have spared their valuable time and have shared their valuable experiences to a very important communication aspect, that is the challenging and the difficult communication that is a day-to-day challenge that most of our physicians and orthopedicians are facing. I would request Dr. Dhiren to add a few words and then we can conclude.
Thank you, Dr. Vikas. We have already overshooted the time, so we will not try to summarize the session. But thank you once again, and we will be again back with a new design of a program. And what Jennifer said, we will also try to do it under the auspices of Indian Orthopedic Association. Definitely we can get actors from Bollywood, from Mumbai, and we can also carry out the similar program in India. So thank you everyone for sharing your experience. And Poonam, now you can stop the recording.
Thank you all. Bye-bye.